Keith Lillymole. I hope that I will have anticipated most of your questions and put them to them. But it's a very interesting group of people. Keith Lillymole clearly is not Irish trained, but has Irish connections through being at Johns Hopkins when a lot of Irish surgeons spent research or fellowship experience in Johns Hopkins. So he knows quite a lot of people and has a good affiliation with Ireland. But we're going to start with Vivian Mcallister. Vivian was a mate of mine in college all those years ago and has had a most interesting career, which took him from Ireland to Uranium City in northern Ontario, and then back to Ireland to do his fellowship and registrar training. And then he went back out and took up transplant surgery and was there in Halifax in Nova Scotia when a lot of the early work was being done on immunosuppression for liver transplant. And he ended up leading the transplantation team in the maritime provinces. And he now is professor of surgery and leads transplantation in London, Ontario. But another interesting thing that Vivian, and he will talk to it in the charter meeting, where we've invited him to talk about from Kandahar to Canada, is that he is a lieutenant colonel in the Canadian forces in the reserves, and he's done 4 tours of duty in Afghanistan with the Canadian Armed Services. So it will be very interesting to hear of the difficulties of running, if you like, a hospital which is a military hospital, which is really one of these ones that you set up with tents and things like that. So in any event, I think all I have to do is ask someone to press the button and we can hear our interview with Vivian Mcallister, which I hope will be of interest to you. Pleasure to introduce my old friend, classmate, Vivian Mcallister, who's professor of surgery at the University of Western Ontario in London, Ontario. Vivian, as you can see, wearing the college tie, is a fellow of the Irish College. I'm sure you had to hunt high and low to find that, Vivian, for today, but you're very welcome.
It's great to have an opportunity to wear a tie, Ronan, and especially to wear the college tie.
Well, I thought you were very formal still in Western Ontario, that it was top hat and tails for most events.
Actually, you know, when I'm thinking back, I haven't worn the jacket either. I think the last time might have been February. But anyway, that has been released.
As you know, we would normally meet at the ACS meeting, and unfortunately, the fellows and members reception, which we would have got together, is cancelled this year. So we're going virtually, which is a great opportunity to meet up with old friends and to have a little chat. And of course, COVID-19 has impacted on all of us. How have you fared in Western Ontario?
I think overall we've done very well in comparison to close neighbors such as Detroit and Michigan, but and even in comparison to Toronto. But you know, life is disrupted. At the very beginning, I was at a meeting in Toronto, and somebody asked me, you know, what did you think about the outbreak in China? And I said, no, they have it under control. I'm amazed at how well they've controlled the thing. Of course, totally naive of what was to happen. And my next experience was when a friend called me up and said, would you join a team to set up a field hospital? And I said, a field hospital? Holy smokes. And then the news came in about what was happening down in Detroit. At that time, they were seeing so many people, and so many medical staff were actually going down with it. There was a fear of a complete collapse of the medical system. And then I realized that really everybody's looking at the wrong thing with COVID. Deaths, sad as they are, will not be a number that will be remembered greatly. But what is remembered is the destruction of the healthcare system that occurs when an outbreak gets out of hand. So that was how it was. And then Western Ontario was very lucky. There were two, I believe, two things that brought this about. One was that the US was ahead of us in terms of exposure. And the second was that St. Patrick's Day was coming up, and they were terrified of what could happen with St. Patrick's Day, and that forced the government's hand. Everything shut down in time to stop celebrations occurring on St. Patrick's Day. And actually, we would have had a very different outcome if we didn't have the shutdown in time for that. So we can thank St. Patrick for saving Canada.
Well, we also closed down for St. Patrick's Day, but unfortunately we didn't close down for the Cheltenham Festival, which was the week before, and of course that was responsible for a lot of the spread. You can imagine, all the punters came back with empty wallets and COVID positive. But there you are.
Well, that's sad. I know. You know, one comment on that. If we had learned lessons from Asia about wearing masks and doing that, I don't think Cheltenham would have been an issue, because outdoor activities are safer. But what Cheltenham might have put us at risk as was meeting in the bars and everything around the race. So anyway, that's a private comment.
Your special interest, of course, is in transplantation, and these are very vulnerable patients. How has that been affected?
So we immediately met about it and decided life-saving transplants should go on. I actually voted that I considered kidney transplantation life-saving and we shouldn't waste good organs. But in actual fact, we stopped kidney transplantation. We continued with liver transplantation. We also continued with emergency general surgery, as everybody did. So I was involved in both of those things. So in fact, my work slowed down, but I continued working throughout the pandemic. And then we gradually reintroduced kidney transplantation, and we're back to normal surgical activity and trying to play catch up.
And have you created a separate pathway within the hospital, a COVID red type pathway and a non-COVID green type pathway?
Yes, we had those zones. So with respect to transplantation, because these are patients coming in, we decided that both the donor and the recipient had to be proven COVID negative. And at the initial outset of that, we said within 24 hours, and then occasionally we'd slip outside our 24-hour restriction with the tests and caused a lot of heartache. But that's how we did that then, and we had known they were COVID negative. We also were doing COVID testing on all our emergency surgery patients, and that switched to going to just screening with questions and testing only as required. But we kind of move back and forth between those requirements. And I actually get confused what's in operation at the time. I leave it to others and tell me it's okay.
But we now have a situation, if you want to have scheduled hip replacement or hernia repair, that you have to be screened COVID test negative before you come to the hospital.
Yeah, so that's because of that, we actually moved just to a screen test negative. So if you pass the screen, you don't have to have a COVID test. If you fail the screen, you have to have a COVID test before you can have surgery. But again, Ronan, this all depends on background prevalence. So if the prevalence goes higher, our restrictions get higher. And I think Ireland might be a tiny bit ahead of us on that.
Well, certainly Dublin now, I'm afraid, having had a very low prevalence, it's up over 100 per 100,000 population right now. So it's really we're almost facing into another full lockdown.
Yes, I heard you're restricted to the county. I heard my sister told me you can't go to Bray, but you can go to Berlin.
Well, even now Berlin has shut us down. You have to be. So there you are. Are there any positives that you see? I mean, looking forward, having had this experience, do you think there are any positive things to take from COVID?
Oh, lots of lessons learned, and lots of opportunities for change in the future. I'll start about maybe our own generation and direct experience. A lot of us are slowing down, and I think it forced some to take on retirement, and this has opened up some jobs for others. At the same time, team approach to care has been solidified. So I can see us, I don't necessarily call it job sharing, but there will be more places for surgeons in hospitals, and the days of working 36 hours without a break are over. So these are changes where I think the new generation who never wanted to take on the lifestyle that we had when we were younger, I think the pandemic will be remembered for pushing these changes through. So I think they're positive, and they're all going to be good. It's going to be a higher standard of care, more people working, a better lifestyle there. So that's in terms of that. Within the hospital, it's been interesting. You know, there were times when you couldn't change anything. You know, we'd lost total control of the operating room, and we just had to do what we were told. And at the beginning of the pandemic, we couldn't even come in the door we wanted to in the hospital. We had to go around to a single entrance. And, you know, you've lost complete control. But at the same time, the hospital had to come to us to say, how do we respond to this? So we formed action committees and setting up things like field hospital, COVID testing stations outside. All these things forced us to rethink how we deliver care. And I think that's going to have a positive effect, lasting effect, because we do need to rethink it. We've boxed ourselves into some difficult patterns.
Of course, distances in Canada are vast, and telemedicine would have been something that I guess had been used quite a bit. I mean, you had experience up in the north early on in your career. Has telemedicine taken a leap forward?
Huge leap forward. I'll tell another story that relates directly to the two of us. One of our classmates, Dick O'Reilly, is a psychiatrist here. Yeah. And Dick had done a study in which he randomized patients to telemedicine for psychiatry or live meetings with patients, and looked at outcomes. And it was a very good study. He looked at several hundred patients, and this was published a few years ago. Well, now it's his most cited paper. It's become hot news, and they're using those techniques to apply that type of care. And even preoperative assessments are being done now that way. And I've done a lot of postoperative reviews of patients. I do it mainly by telephone. I find the camera part doesn't help me an awful lot. But so yeah, telemedicine is definitely here, and a lot more practical approaches to patient-centered care. What works, you know, what the patients need and want themselves. So having a patient here come maybe 100 miles, wait 2 or 3 hours to come and see me, and then all I do is shake their hand and send them away again. That's not going to happen anymore. However, on the other hand, if I do need to see somebody, the waiting time is now much shorter. I see them immediately, get it done, and try and get all their appointments at the same time, so they have a single visit to the hospital. So again, all of those things are good developments that we can apply outside the pandemic as well.
And how are you managing the exams, the fellowship exams in Canada or the North American boards?
Yeah, so the fellowship exams were cancelled, and our plan is to run the written portion of the exam this year and forego the live portion. I'm not certain. We haven't, as far as I know, in general surgery, we haven't done it yet. It's coming up soon. And I think that with respect to the cohort that we examine, that we'll probably have just as satisfactory an experience. There will be one or two candidates who benefited from being present in a live exam, so that they got the benefit of the doubt that they didn't get in automatic exams, whatever type you use, and they're going to be hard done by. But I suspect our whole exam program will change for the future, but it's still an evolution. I mean, partly it's how do you take them? So one of the schemes that I think is there, that there'll be, you do it in front of your laptop with the camera on the whole time, and it's invigilated that way. The other is that you go to centers and it be done, and there was talk of blocking hotel rooms. You know, there's all sorts of things, and I'm not 100% sure what the strategy is going to be.
Well, I was on a webinar yesterday with the 4 presidents of the Royal Colleges in these islands, and it's exactly that discussion. And the membership is going to be a mentored laptop, but we're looking at 6 centres, 1 in Dublin and 5 in the Great Britain, for the intercollegiate fellowship.
Yeah.
And not having patients, just having actors.
Oh, actors. Yeah. Well, you know, we had, why not? But, you know, it was amazing how we did the exams with live patients. In Canada, it never happened.
Oh, really?
No. They had moved away from live patients maybe in the 1980s. So all the exams I did were either hypothetical cases, and that's the way the college in Canada has done it for 20, 30 years. So you just give hypothetical cases, and we had, it used to be, it wasn't scripted. But then initially we scripted the questions, and then we scripted the answers. And now the questions and answers are kind of scripted with different ways that the exams can go according to the answers. Yeah. It's become very complex. But
it's almost a science in itself. And last question, the trainees, how's their experience in terms of cases and their logbooks? How's that been? And is it impacting on their progression?
I'd say no to the current group of trainees. We always had a relative shortage of trainees to positions available. And over the years, a trainee might have been assigned to 3 and 4 surgeons, where they were only assigned to 1 or 2 years before. So, and we've also had strategies for dealing with long holidays, such as Christmas time and New Year's. So we went into that type of mode for the pandemic, and the trainees have been working all the way through because they're frontline workers like ourselves. The people who were really impacted are the medical students. They were actually sent home, and they've only come back, and the first 2 years are doing all of their work online. And that's going to be a new cohort to deal with when they actually get to the clinic. We've brought in sort of mentoring projects where students are assigned mentors. I've never been a fan of these mentoring programs, but they're absolutely needed now. And I'm trying to meet my students in the hospital, if we can get permission. Hopefully next week I'll know, and at least give them a taste of being in the hospital. So that's, I think, the group that were affected the most.
Yeah, we're trying to get, and we have, I think, a government acknowledgement that certainly those in the clinical years are essential care workers and will work under the same regulations as essential care workers.
Yeah, our clerkship years, the 3 and 4, are back in the hospital now for the last month. and I think they will stay. Peculiarly, you know, when I was on that task force at the beginning for the field hospital, I actually suggested the medical students come down and run the place, and they thought I was crazy. But anyway, that's what we would have done in a world war. But
well, there you are. That's another day's discussion. And Vivian, I'm really grateful to you for joining with us. Hopefully, we'll meet in person in the not too distant future. And our very best to Christiane and the family. And thank you.
Thank you very much, Ronan. Good luck to the college and to you. With your leadership, I know you'll come through this and actually have a stronger institution as a consequence. Thank you.
Well, I hope you've enjoyed that. I have to say, Vivian is really quite understated, but I think you would get a sense that he really has a handle on what's going on and is a real leader within Western Ontario. And indeed, he's very well acknowledged within the Royal College of Physicians and Surgeons in Canada. So we look forward to hearing Vivian again at the Charter meeting when he will talk about the field hospital in Kandahar and how he adapted his experience from Kandahar to London, Ontario. Our next speaker is Magella Doyle. Magella was an intern, I think, and possibly an SHO with me many years ago in the Mater Hospital, working with Jerry McEntee and myself. And she did her training in Ireland and went off to do a transplant fellowship at WashU in St. Louis, Missouri. And they liked her so much and she got on so well there that she has stayed. And she's now Vice Chair of Clinical Operations at the Department of Surgery at WashU. So if we can, Pauline, if we can start that interview with Magella. Thank you. Well, our next alumnus is Dr. Magella Doyle. Magella, it's a long time since we worked together. I think it was in the Mater in the mid-90s. When did you move to the States?
I moved to the States in 2005, and yes, I have extremely fond memories of working that busy SHO job with yourself and Mr. McEntee in the Mater Hospital.
I'm sure I was the easier taskmaster. I don't think Jerry.
Of course.
So now you've risen to great heights. You're head of liver transplantation at Children's in WashU at St. Louis, and also vice chair of the Department of Surgery. These are onerous responsibilities in the current environment.
Yeah. Well, I'm vice chair of clinical operations now in the Department of Surgery. Not quite the vice chair, but it's certainly busy. And I have a busy practice in transplantation, abdominal transplantation, along with a busy cancer practice in hepatobiliary surgery. So it certainly keeps me busy over here. So I've been here now for 15 years. And it's an interesting how things work out, because I came here for 1 year to kind of do more training and ended up here 15, 20 years later. So. Well,
I mean, when you come to a fork in the road, take it, I guess, as Yogi Berra used to say. That's what happens.
Yeah, that's what happens.
How did COVID impact on your practice?
Well, initially it was kind of crazy. We were at our annual meeting in Miami, and some of our New York colleagues had been banned from travel, and we were sort of all reeling as to what was going on. I think the cases in New York were just building. It was right at the beginning of March, and over the 3 or 4 days of the meeting, it became apparent that this was incredibly serious. And so we all were sort of, anxious to get home. And of course, that was the last meeting we've been at, because everything has either gone to virtual or has been cancelled since. Our institution quickly put in a travel ban. We weren't allowed to go anywhere outside of 60 miles, and certainly no travel to meetings or anything like that. And we pretty much stopped operating within a week or two of the New York impact. And this was just an enormous change for everybody. There was many people, there was a lot of fear, a lot of confusion. I think we instigated quickly, having daily calls, daily emails to sort of update people as to what was going on. There was a lot of fear over PPE. And, you know, we had to get used to reusing all our masks, keeping our masks in brown paper bags. We were fitted for N95s, but we were only given 2. We went on to have sterilization of our masks, which was, again, a weird concept that we all had to get used to. And it's incredible how quickly something really odd becomes the norm. You know, and now we walk around with masks, as you all are doing over there, with complete normality. I think for our practice, oddly, in transplant, yes, there was a complete lull at the beginning. I think all of the hospitals were just, donors just stopped, basically. There was just no donor offers. And I think this was because families weren't in the hospitals. People were scared. We didn't have enough testing. We didn't know if donors were positive. And so basically for about 2 weeks, we actually published our results in of several OPOs, which are the organ procurement organizations in HAT, looking at this downturn and then the sort of the creep up. And so once testing was in place, and I mean, this was still very limited testing, but we were testing the donors. And once we were getting the results back, the donor offer started to creep back up, and we started to go to work. And honestly, our transplant business was as busy, if not busier, over the initial 3-month period than we've ever been. And all our patients were categorized, not just in transplant, but across the department, according to the ACS guidelines, you know, tier 3 down to tier 1. And as a result, many of the transplant patients were in the high tiers. And so we were continuing business as usual. The cancer patients, I'm sure no more than in Ireland, you know, were definitely in a quandary. Some of them, of course, needed surgery, but whoever could be pushed to neoadjuvant therapy, we did that. And much for the safety of the patients and their comfort, as well as to keep capacity in the hospital.
Was there much difference between children's and adults?
You know, the children's hospital was interesting. There was never very many patients in the children's hospital at any one time, but the children's hospital were making space to take the overflow from the adult hospital. And so there was definitely all elective surgery was stopped there as well. But we did as many kids as we did adults during that same time period. So it was very interesting with transplant, how we really didn't, our practice was very busy. And of course, going to donor hospitals, we were also nervous and worried, you know, because you were being exposed to a whole other hospital. We were going in an ambulance, we were going in a plane, we were traveling with our colleagues and our peers. And, you know, it was definitely concerning. Obviously, we were wearing masks, but, you know, we were worried about using PPE. It was a very confusing, stressful time in the beginning. But like everything else, we got used to it, we adapted. And I think once we knew that the donors were all being tested, we felt much more comfortable being in the operating room.
Can I ask about staffing? Because one of the issues that has come up has been that because schools were out, that healthcare workers were finding it difficult to come to work.
Yeah, for sure. It was very challenging. And of course, the hospitals were also trying to manage not just OR staff, but, you know, nurses on the floor, admins, and rapidly transitioned to a work from home environment. So people were given laptops to take home. IT services were on board very quickly with getting people set up with VPNs at home, being able to log into the hospital system, et cetera, et cetera. And so that actually worked very well. And I think helped a lot of people be able to continue their jobs if they were in a work from home capacity. Of course, for the physicians and nurses, it's a little more challenging. But there were several staff who decided to take a break, sabbatical, and minimize their work environment because they were worried. There was talk at one point, because we weren't sure how many patients we were going to get, that the ORs could be converted into ICU beds. I'm sure it was the same in Ireland. And, so many of the nurses were very nervous, particularly in the OR too. And then the type of surgery that was being performed, we pretty much stopped all laparoscopic and robotic surgery because people were fearful of aerosolization of the virus. But I think, again, with everything else, once we quickly were able to move into testing the patients who were coming in for the operating room, and the staff knew that the patients were now going to be tested and were going to be negative when they were coming into the OR, I think that allayed a lot of fears. It was really just about trying to allay confusion and minimize fear.
So what's good about the new normal? What benefits are there?
Well, I think Zoom is incredible, and instead of getting up and leaving for work at 6:15 every morning, I sometimes now have the luxury of taking my 7 o'clock Zoom at home and being there for breakfast with my little 3.5-year-old. So he loves Zoom as well, and I think that's one of the great benefits. I think from the patient perspective, one of the huge innovations that we've been talking about and trying to do for a while, but really was rushed in, is telehealth, telemedicine. So for patients, particularly here, they travel from so far sometimes to come see us. It's such a luxury for them to be able to see us and have access to us easily in person by Zoom. And there's no comparison to a phone call, I think, to being able to see them face to face. And so I think the patients love it. We're working on strategies right now to try to look at patient satisfaction by using Zoom versus coming to in-person clinics. And I think that'll be interesting to see. But we've certainly had a lot of interest from the patients, particularly for their follow-up by telemedicine. And
how do you document those interactions?
So we have an electronic medical record called EPIC, which is pretty universal, or at least it's used in a lot of places in the US. And the meeting is actually initiated through the electronic medical record. So the time that you're on the call is documented. And then in your note, you can also document how much time you spent preparing for the meeting. So. Okay. Yeah, it's all very clearly and carefully documented with a note afterwards.
But the actual discussion, is the audio or video is not recorded?
It's not recorded, no, but you document it just like a note. If you were in the clinic, you just put in your note, but you say it was a telehealth visit and detail the details of the conversation.
So that seems pretty seamless.
It really, I mean, of course, there were hiccups in the beginning, and there's still hiccups because not every patient is computer savvy, and it seems like it should be straightforward, but it's very challenging for some of the patients. So there are still days like I have clinic in a little while, and I've it's mixed inpatient and Zooms. And so we're over in clinic and we have a Zoom room where we go into the room and take our Zoom. And but sometimes we still end up having to call the patients because for various different reasons they can't log on.
And how have your residents coped? Have they been shorter cases?
The residents and fellows are catching up. So there was definitely a period of time where elective cases were missing. We're more fellow heavy on the transplant side than residents, and our fellows didn't suffer at all because we were busier than we'd been. So they've done fine. But the residents are having a little bit of catch up. But the residents were also pretty busy throughout the period as well with emergencies. But they had a period of time where there was no elective cases. Yeah.
Well, I don't know about you. I don't miss the travel, but I miss arriving because at the end of it all, there's good friends and colleagues and indeed family at the end of the travel. Yeah. What do you see as the future of American College meeting and other meetings like this?
There's such a divide between virtual meetings and where we're going. So are cancelling meetings. We've had several meetings cancelled. We have several meetings virtual. We know the ACS is going to be coming up here now virtual. I was participating in a meeting in hosted in South America last weekend, and there were 1,700 participants on the call, which was absolutely incredible. And because I was on an international meeting the week before, and there had been far less participants. So I think it's very variable as to the level of participation. I do think when you have a virtual component to the meeting, it's going to deter some people from traveling. But I think we're all just looking forward to having the opportunity to go and see each other again, because it's a huge challenge missing the connection and the networking with your colleagues.
Sure. Well, we sincerely hope you'll have the opportunity to meet all the Doyles back home in the not too distant future.
I know it's been on a personal level, it's been very challenging being over here and being away. But I know it's shared throughout the nation, because whether your family is overseas or whether your family is in a different part of the country, it's been challenging to go and see for everybody. So, but I look forward to being home soon.
Well, Magella, I hope you'll drop by the college and say hello. Thank you very much indeed.
Thank you.
Well, my goodness, how successful Magella has been, and very interesting to listen to her reflections on her life in WashU. She's very successful as a transplant surgeon, as you can hear. And also many of the issues that they've had are issues that are universal in terms of coping with COVID and how they're getting on now. I think it's also very stimulating for our trainees who are listening in to just hear how successful graduates from our programs have been abroad. Reflecting the very, very high standards that they bring with them from their training in Ireland. So it's very gratifying. We're now going to listen to Conor Delaney, who I'm sure is known to all of you. Conor is the exemplar of success in North America. He is now Chief Executive Officer and President of Cleveland Clinic, Florida, having been the chief of the Digestive Diseases Institute at Cleveland Clinic, Ohio, where he was looking after all digestive diseases and surgery in the Cleveland Clinic, and still maintaining a practice. Conor has extraordinary management strengths and people management strengths. So I look forward to listening again to the interview I did with Conor a couple of weeks ago, and I hope you'll enjoy it. Thank you very much. I'm delighted to welcome Professor Conor Delaney, who is one of our own and currently chairman of the Digestive Diseases Institute at the Cleveland Clinic, Ohio. But good news, he's just been appointed CEO and president of the Cleveland Clinic organization in Florida. Conor, many congratulations.
Ronan, thank you very much. Appreciate it. And it's a pleasure to be with you here today and have a conversation.
Yeah, I'm sorry we're not meeting at the ACS in Chicago, but that's the way it is, I'm afraid. But we have this virtual meeting to celebrate with our alumni and our fellows and members who would ordinarily meet with us at the ACS. Conor, you talked to us earlier in the year about the initial effect of COVID at the Cleveland Clinic and how you coped with it. But I'm interested to hear now how you're adapting to the second wave.
Right. So we've had a very different experience at all of the different hospitals and different regions, whether it's Ohio, Florida, Nevada, whichever, and also based on specialty and then based on main campus versus the region. So initially we worked fast to come up with criteria for what surgery could be done. And we worked on protocols like everybody else, masks, spacing, social criteria. And we very quickly integrated a testing program. We set up testing here, PCR-based testing, very early. And so then we used that and integrated that with pathways so that patients coming in for surgery with anesthetic would be tested within 24 to 72 hours before surgery. And then patients having outpatient care don't get tested, or outpatient endoscopy off a surgical site. Once patients are co-located, they all get tested, and it's treated almost as if it's a bubble for that day. And then we did a lot of work around caregivers and caregiver support, because even with everything that was being done to protect them from the disease, and there was obviously a lot of stress for caregivers. So hardship fund set up, a lot of psychological support put together, counseling, stress-related services, childcare services. And so they were the first few weeks of trying to adapt and getting into what our new normal was. And so now, really, maybe a little different from Europe, we did have an initial first wave, but there have been a couple of smaller, more recurrent waves around holidays and things like that. We haven't noticed anything with going back to school or college, because obviously kids are getting it in college, those that are in person, but they tend not to get as sick and not to come into hospital. And the most recent holiday here, which was in early September, the Labor Day holiday, there really was no surge. So it looks like society is adapting to it and adjusting to the new normal, and listening to the education and protecting themselves. So from a social perspective, it's working well.
Are you persisting with the PCR as being, that takes like 16 to 24 hours to come back? Or are you looking at new ways of doing maybe antigen testing?
So actually we do PCR, but we've multiple PCR testing platforms. So we have a routine that is meant to come back within 24 hours, but we usually get it back within 12 to 14. So we develop the testing here, and it's all been done in-house. But we also have rapid testing platforms, which come back in 1 to 2 hours. So we'll use them for emergency surgical cases. But we have protocols and algorithms which are all available on the web. But so emergency room admissions will all get rapid testing. Elective surgery for next day or a couple of days later will all get routine testing, and it's all very protocolized. But we use different types of tests for different types of population.
And have you created a separate pathway for emergency surgery within the institution?
Not a physical pathway, but yes, in that they will get rapid testing as opposed to the routine 12 to 24-hour testing. And as regards pathway then, so if they're positive, or there are PUIs, as we call them, persons under investigation, if they need emergent surgery before a test comes back, then they all get managed as if they are positive. And so it's N95s for caregivers and all of the various things that follow with that.
I know you're familiar with our system in Ireland, and we now have the winter care plan, where the idea is that we need to find another 1,500, 2,000 beds and staff them. What would be your advice to us, coming from your perspective?
Yeah, so it's interesting. So the recovery and going into winter phases are really interesting conversations. As regards beds specifically, I think we've certainly, most facilities in the US now have got over the capacity constraints of bed utilization. And it's largely not because there's necessarily a huge number more beds per capita. We probably do for ICU, certainly here within the clinic. I think we've got 450 in Ohio, so that gives us a good buffer for ICU, and we haven't reached that. But for the hospital beds, which can become a pressure point with surges, the way we've managed it for decades now really is with care pathways and very careful focus on length of stay. So people come in, and a lot of it's pre-hospital education, and if people are coming in through the emergency room for other reasons, it's in-hospital education. It's having nurses on board, physicians on board, care pathways and order sets on board, and it's around the old stuff we published 20 years ago on Fast Track, or now Enhanced Recovery, and we do similar things with all the medical care pathways. And so it comes down to managing length of stay. And so obviously if you have somebody who stays 7 days versus 2 people who stay 3.5 days, that doubles your bed capacity. And so institutions in the US manage it through very carefully focusing on length of stay.
But that then predicated on a rapid readmission pathway if necessary.
So absolutely, you need a readmission pathway if necessary, but after 2 decades now, we clearly know that readmissions rates do not go up with these pathways. So, there's no increased readmission burden, but that's something you need anyway, obviously, to be able to manage readmission. And so there's various other things that we would have in place with follow-up with patients who are discharged, with managing medications for them. Obviously with virtual health, it's something we've been doing for close to a decade, but we've scaled it up very significantly now. That's something that's varied across practices. Our gastroenterologists probably hit 95, 96% at their peak, and down to about 25%. Surgical practices, all depending on specialty, whether it's cancer or transplant. But we've also used that to allow us help the patients after discharge and check in with them remotely. So distance health and virtual health platforms have been very helpful. And then we have and are extending and building some in-house care pathways and nurse visitation to patients at hospital, in their home, to reduce the risk of them being readmitted. So there's a lot of parallel pathways to minimize it. And yes, you need to be able to manage readmissions, but reducing length of stay doesn't increase readmissions.
And what are your big ambitions for the Cleveland Clinic in Florida now that you're moving south?
Yeah, so it's really exciting. We have a fantastic team there, and people are most familiar with the Weston campus, which was the primary campus there. Over the last few years, we've actually extended north, so we now have 5 hospitals on the east side of Florida. And the ambitions are, just to scale the group there. We have a lot of talent. We'll build subspecialties throughout the region, and then we're expanding. We'll be a larger system in the near future. And so the excitement is the opportunity really to bring the Cleveland Clinic care pathways and practices to a larger number of patients, because that's been our mission across the organization.
We might have to get you to extend them out to the HSE at home.
Well, there is good direct flight access to Fort Lauderdale and Miami, so we'll help if we can.
Conor, we're looking at challenges right across the healthcare system, but do you see any positives coming out of this COVID experience?
Yeah, I think there's a couple of positives. I think it's certainly, even for us, we like to think of ourselves as a nimble organization, but we're fairly big, and so it takes time to make decisions. I think we've all seen within teams how quickly we can accelerate decision making and how rapidly we can accomplish change. And that's certainly been a learning experience for us. I think the scale of distance health and the opportunity of distance health and remote health is going to be a very significant learning process for this. And then I think probably the other positive is learning to deal with these pandemics. I'm sure there's going to be more of them. We've actually, by coincidence, we're in the process of building a global center for infectious disease in Florida and in Ohio. And it was kind of timely. And so that's just rolling out now. And that's a center that was going to be looking at Zika virus in Florida and other things. And now obviously COVID is becoming part of it. And that's learning that we're going to need as society and as healthcare systems moving forward. I think the bigger challenge is the negatives. And the 2 major long-term negatives, I think, are going to be the fear for patients coming in to get care they need. We're seeing that our cancer volumes, transplant volumes, cardiac volumes, things like that are back at baseline. But the volume of screening colonoscopy and things like that and minor procedures is not. And that's translating into people coming in late. Whether it's people presenting a little later with complications of GI disease, but also reductions in number of people coming into the hospital with stroke and cardiac disease, which obviously hasn't changed. They're just trying to manage it at home and likely not successfully. And obviously the bigger challenge then for us, particularly the way healthcare reimbursement is structured in the US, is the economic challenges to, well, society in general, but obviously to hospitals as well, and the pressure it will put hospitals under.
Conor, as you know, RCSI has the Medical University of Bahrain, and Bahrain has been affected as all of the Middle East and the Gulf region. How have your experiences in Cleveland Clinic in Abu Dhabi been?
Yeah, so we've had, I mentioned a little Florida versus Ohio in US experiences. So we've also got feedback from our teams in London and Abu Dhabi. Abu Dhabi, so one of the really fantastic things about the clinic as an enterprise and being a global enterprise is that we're learning different things from different groups in different places. And Abu Dhabi were a little ahead of us in the speed of their first surge. So we shared ICU protocols. A lot of the people over there have been here, so we have very close relationships. And now we're going to be learning from them about vaccine programs. It looks like, I'm not sure it's final yet, but it looks like Abu Dhabi will be using the Chinese vaccine sooner. So we'll learn about integration of that. Once they got over the initial surge, though, they got into a very stable place. So not as high a surge. They had it, they managed it, we learned from it, and now they're going to be earlier in the vaccine phase. And so we hope to learn from that too.
Good. Conor, thank you so much for taking time this morning to join with us. I'm sorry it's virtual, and I hope that we'll meet at the ACS next year in San Diego.
I look forward to it, Roland. Thank you very much for the opportunity.
Thank you, Conor. Well, I hope you enjoyed that. It was really wonderful to hear somebody so completely conversant and on top of this of the complexities that an organization such as the Cleveland Clinic encounters, and to be able to take experience from Abu Dhabi and Florida and use it in Cleveland, and be able to synthesize care plans and adapt their plans is just an extraordinary ability. So it's great to see Conor succeed. And again, it is an example of the diaspora that we have around the world of RCSI and Irish graduates, which we should be very proud of. We're going to finish this evening with what I hope you'll find is an interesting chat with the Surgeon-in-Chief at Massachusetts General and Professor of Surgery at Harvard, but also he is the Editor-in-Chief of the Annals of Surgery, Keith Lillymole. He and I know each other through editing and through the American Surgical and the European Surgical Associations. And so we had an interesting chat, and I hope you'll enjoy it. And Pauline, if you could run that for me, please. It's a great pleasure to welcome Dr. Keith Lillymole, who, as many of you know, is Surgeon-in-Chief at the Massachusetts General Hospital and also Professor of Surgery at Harvard Medical School. Keith is also Editor-in-Chief of the Annals of Surgery, and I guess it's through the Annals of Surgery that he and I met, and through the European Surgical and the American Surgical, of which he's a past president. So Keith, we're really grateful that you would join this video link. It's being held instead of our usual fellows and members meeting and reception at the American College of Surgery Clinical Congress. Keith, we wanted to hear from you a bit about how the Annals coped with the COVID epidemic and the huge interest in COVID and surgery, and I guess the large number of publications and manuscripts that came your way.
Well, Ronan, thank you for the invitation to connect with all our friends in the Ireland organization. Friendships that have gone back for me to the days of a resident at Hopkins when we used to have an exchange with the Royal College of Surgeons of Ireland. But it's always a pleasure to see your group. We hosted you in Boston not too many years ago, and so I'm happy to be part of this. COVID for Annals of Surgery is, I guess the best word to say is be careful what you ask for. When COVID started coming out and there was a lot of publications starting to show up in the medical literature, we realized that it was a surgical problem as well, not just in the risk to surgeons in the hospital environment, but issues in taking care of COVID patients safely and running our practices safely and efficiently. So we sort of to just sort of call for submissions, and that's what I mean. Be careful what you ask for, but that really turned on the floodgates. You asked about numbers. I think at our last count, we're probably close to 700 COVID-related papers submitted since March, and we've accepted and published about 100. That works out to be about 14% of the papers that come in. Now, fortunately for the review process, most of them in the early stages were brief clinical reports or surgical opinions or surgical perspectives, which were limited in terms of the number of words and the number of figures. And so it was a lot of work. And I have to say that, like many of the leaders, most of my time during COVID, I wasn't operating, I wasn't going to the meetings, there was no sports for me to watch. And so I was pretty committed to making this work. So I took a lot of it on myself, but we had great associate editors that did several of them in certain niches. And the review process went pretty smoothly. Fortunately, our publisher was very generous in putting them all online on the website, open access. I would say the papers were a mixture of sort of early surgical experience, some opinion pieces about topics from everything from aerosolization of COVID during laparoscopic procedures, also management of cases as you're decreasing and how to control the cases that you do. And then as COVID, at least in parts of the country, sort of went down, how you open back up to normal activity, telemedicine, virtual interviews for our residency and fellowship processes, education. We covered the whole gamut of topics. I think we did a pretty good job. I would say that there was probably some papers that would come through now that we wouldn't have accepted, because when they came through, we thought they were maybe more valuable than they would be, because we just didn't know. And as you said, we were trying to do a service to the specialty by getting that information out in a quick, rapid fashion. And I really have to give thanks to our publisher for sharing it on open access. And it's still available on open access for anyone who wants to go look at what people were doing then and project a little bit of how they're moving forward in the future.
We're now facing a second surge here in Ireland. We've partially closed Dublin down, actually, again. How are you doing on the East Coast of the States?
Well, the United States, again, the East Coast, particularly New York, New Jersey, Massachusetts, got hit pretty hard in that first wave, probably 2 to 3 weeks behind Europe, maybe a little further behind Italy, but the rest of Europe, we were a little bit behind. And I think, it's a big political issue. We might have closed down better and we could have done a better job of closing down. But the bottom line is, since it's gone down, and I guess the numbers probably would be in late May, we sort of went down. We have not seen a surge yet in Massachusetts. Now, Massachusetts is a big college town. And so as kids are coming back to go to college, the numbers have gone up in terms of testing, which obviously the schools are requiring them to test. But in terms of the number of patients in the hospital and sick patients, I think the numbers have stayed pretty low. Now, that was the East Coast. And then as you probably followed in the news, it then sort of went across the United States, hitting areas like Florida, Arizona, Texas, and parts of California much, much harder. And I think, again, I do not want to make this political, but those were states that really said, we're not going to restrict, we're not going to require masks, we're not going to shut down and risk the economy, we're going to keep our beaches and our bars and things open. And I think they paid the price. I think they've gone down now, and other areas around the country are starting to spread a little bit. Even, you joked, my native South Dakota had a big surge after they brought in 400,000 motorcycles to a big rally that they have in western part of the state. So, wisdom, I think, and being safe, I hope we can keep people from getting as sick. I think the numbers will rise, but hopefully they will not be the terrible level of death that took place in the early phases.
And just training, we're having problems with our training numbers for our trainees. Has it had an impact?
Yeah, I think the chief resident class finished with less numbers because they really did very little surgery during, I guess you'd say, March, April, and May. Now, overall, I think our numbers met the American Board of Surgery requirements. I think the American Board of Surgery did lower those requirements a bit. And I would say probably since the end of June, 1st of July, we've been operating at a pretty normal pace in terms of the number of cases that are being done.
And the last question, the exams, the American board's exams, there were problems there, I believe, in terms of holding the board exams?
So this was, there's been two components, as you know. The American board gives first the written exam and then the oral exam. And the oral exams have been delayed. They've done a few pilots with virtual interviews, somewhat like what we're doing now. And overall, I think they're going to be okay, and they're going to move ahead with those. The big problem happened with the written examination, and that took place in July. And there were some security breaches and some real issues with connectivity. And it was supposed to be a 2-day exam. And after the end of the first day, they just quit. And it really created a big issue for a lot of the trainees because many of the fellowships are now deferred to start on August 1st. So they've been studying for 2 or 3 weeks and prepared. Now, you know, they've been back in their fellowship and doing cardiac or vascular pediatrics or transplant, and the opportunity to study is sort of diminished. So,
well, we're facing much the same dilemma with the membership and fellowship exams here. Keith, apart from the effects on surgery itself, COVID, I think, exposed some issues about equality and access and diversity. Would you like to explore that?
Yes, Ronan, I'm pleased again to say, you know, when the COVID started going down and we were being a little bit more selective about the manuscripts that we were giving full review to, was about the time our country really got caught up with a lot of problems related to social injustice, equity, diversity. And then even more recently, there's been this surge of concern about diversity and inclusion in the editorial review process with respect to a membership on editorial boards, access to being writing editorials for feature articles, things along those lines. And there has been a call for action by the Surgical Editors Group that has addressed this. And so Annals sort of, again, I didn't learn from COVID. I sort of turned our attention to looking to accept and fast track and publish papers that we felt were important related to diversity and inclusion. And we've had a couple of very important statements, one from the American Surgical Association, one from Annals related to the process that I think is, again, showing that we recognize the problem and we're going to do what we can as a journal to not only publish papers, well-done papers on these topics, again, make them open access on the website, as well as look at the diversity of our editorial board and other aspects. And I think we do a good job from the perspective of gender, but like in many things in our country and in our specialty, I think in having racial diversity, we still have a long ways to go.
And do you think that the journal, the Annals, publishing in the Annals will move the political agenda, or is there a group think amongst the surgical editors that this is really something that all of the journals should approach?
I believe the last count was of all the surgical journals, 120 have taken this call for action to add diversity to their editorial boards. And to look at how they're doing to establish metrics. One of the things we have to be careful with is that, you know, if we over proportion the number of minority or female reviewers, it's sort of a tax on their time. So we have to be respectful. But again, inclusion on our editorial boards, I think, is something that everyone would value the opportunity to do. And we're certainly trying to take the lead as certainly one of the oldest journals and one that I think still is one of the most respected, that I think if we set the bar, I think others should follow.
Keith, we really do appreciate you taking time out of your busy day. And I'm sorry that you can't visit us as a group in Chicago. And I'm very sorry I can't join you at the Massachusetts General Fellows and Alumni gathering as well. So
that was a great social event to see everyone, and I look forward to hopefully by October 21 we'll be back to a new normal and getting together.
I look forward to it. Keith, thank you so much.
Thank you, Ronan.
Well, I hope you've all enjoyed this series of short interviews, and particularly the opportunity to listen to Keith Lillymole. And I'm very pleased that we managed to include the section on equality, diversity, and inclusivity, which is a really important issue that during my presidency we will try to address as best we can within RCSI. And I know it's an issue that is topical amongst the surgical and particularly the non-training junior doctor fraternity. So this is an issue that is important and that we will continue to try to address. So it's good to hear it from Keith Lillymole. Unfortunately, there is, although there is a chat function, I can't pass on your questions directly to our four speakers. But I hope that over the last hour, I've managed to address most of the issues that you would be interested in. I think it's an interesting format. The ability to do this online with people who are many time zones away allows us to put together a program like this. And in that regard, I want to thank particularly Robin Beert, who from the Members and Fellows Office, who was really the mastermind behind all of this, and also thank Pauline Lyons and her colleagues for putting it together for this evening. It may have looked seamless. I can tell you that there's always a lot of editing that goes on behind the scenes. I see Kieran wanting to come on, and have you anything to add?
None at all, President. No, just come on to just say thank you very much. That there were very interesting talks, and a very good format actually to get that sort of perspective on things. So well done.
I just would, I think we are planning, and the Vice President, Laura Vianney, I see Laura is online as well. Laura is planning the topics for the next semester in terms of our Wednesday evening webinars. So it would be very helpful to us if we had suggestions as to what you might find interesting, and also feedback as to whether you found this format of doing a number of interviews and putting them together with people who are, as I say, many time zones away from us, so that we can get the opportunity to have input. And I'm thinking particularly of colleagues in Pakistan or Sudan or India or the Far East that we might wish to interview and discuss topics that you might suggest to us. So with that, I will say good night. Thank you for attending, and thank you again to Pauline Lyons for being the whiz behind all the workings of this tonight. So thank you and good night.